Hi everybody, welcome to the Dairy Australia Clinical Mastitis webinar. I hope you're all staying safe with regards to COVID, and yeah, it's a great opportunity to bring everybody together and share a little bit of the happenings within DA with all of you out there. Before we begin, I just want to run through a little bit of housekeeping. So for your information, the webinar will be recorded and made available to those that have registered after the webinar. You'll see that you've all been muted and got your camera turned off. So that's just so that we minimise any disruption to the webinar as we roll through it. We'll be holding question time at the end, but if you do think of any questions during the presentation, please just enter them in the Q&A section. So if you're on a laptop or a PC, you can find the Q&A click button by hovering just down the bottom of your screen. If you're on a smartphone, if you tap the screen, you'll see that there's 3 dots on the right-hand side, and you can follow the navigation to the Q&A box from there. We will be reading out the questions, but just for your information, we will be, when we do read them out, we won't be saying your name. So if you're a little bit nervous to ask a question just because you don't want anybody to know, we will be leaving your name out when we're asking the question. So don't be shy, ask plenty of questions. If you would prefer to ask your question by speaking it, or if we need some more clarification, there's a raise hand function also at the bottom of your screen. Yeah, let us know if you want to talk to your question. Also, please feel free to use the chat box if you're having any issues during the webinar. We're really lucky to have Sarah Thompson on board, who's going to be helping us with the technical support to get through it all this afternoon. So there's been a lot of work going on in the mastitis space at Dairy Australia over the last couple of months. This is the last of a series of 3 webinars. The first 2 webinars that we held were for vets and milk quality advisors to bring them up to speed with the latest recommendations around managing clinical mastitis and mastitis diagnostics. And now it's time for us to share this knowledge with you. So we're hopeful the way in which we've structured the webinar series means that your advisors are well prepared for any questions that you might have that come out of the webinar. The other really exciting thing that we're looking forward to telling you about, we've been busy developing a brand new program called Mastitis and Milking Management. And essentially what we've done is packaged up the fundamentals from the industry's renowned Cups on Cups Off course, Cups on Cups Off training program. But you can complete those fundamentals via an online learning program with some on-farm practice. So it's really designed to bring new or less experienced staff up to speed with safe animal handling, milking procedures, and prevention and identification of clinical mastitis. So that's going live in the pilot phase as of Monday, which is really exciting. So if you're interested in registering yourself or any of your employees, or you want to find out more about the course, please contact your local regional development program. So our presenter today is Dr. Mark Humphreys. So Mark is a preventative health vet and educator based in the McAllister Irrigation District of Gippsland. He's the Countdown project leader and more recently as a project lead in antimicrobial stewardship discussion group programs. He continues to hold discussions on how farmers will be working towards reducing mastitis on farm and also to improve the management of mastitis, particularly as it relates to the use of antibiotics. We're really lucky to also have on the line Dr. Zoe Vogel. So she's a cattle vet from Timboon, so the vet group in Timboon in Southwest Victoria. And Zoe presented the advisor webinar on mastitis diagnostics. So when we're talking about mastitis diagnostics, predominantly talking about on-farm culturing. And she's here to answer any questions that you may have brought to the webinar at the end of the session. So without further ado, I'm going to hand over to Mark.
Thanks very much, Steph. So if we've got some questions here that it'd be great to get some feedback from those of you that have work on dairy farms. I've just put a few questions there while we're making some introductions. Just checking, Sarah, the video's working okay?
Everything's perfect, Mark, and the poll's up and running.
Okay. Good. Thank you very much, Steph, Sarah and Zoe for your work. There's more acknowledgements at the end, but yeah, it's I'd dearly love to be, instead of over a webinar, I would dearly love to be working with you on farm or in your local hall. But the reality of our geography and the current restrictions mean that perhaps this is a good way to connect and think about how we can make some improvements to our businesses. So yes, as Steph said, there's been a lot of work done in this area. I suppose traditionally, you know, with Countdown, there's been a lot more about prevention, but for the last few years, probably starting in 2015 with John House and Kira Petrovsky, we've started to do a lot more work in the treatment space to be able to provide good support to those prescribing treatments for clinical mastitis, but also those using them. So there's a lot in the webinar. It's impossible to cover everything, so we've allowed some time at the end for some good questions. And if there's still more opportunity and query, please feel free to get in touch with me or Steph or Zoe after the end of the webinar. I'll leave my contact details on the last slide. So I'd dearly love to be talking the whole time about prevention, because put simply, you can never treat your way out of a problem. You know, plenty of farmers and vets have tried to do that, but it's not successful. And so I'd dearly love to be talking about prevention, and that's how I spend most of my time. However, there still are opportunities within treatment to minimise the impact. And also throughout the course of this webinar, you'll actually see some real opportunities for saving money and supporting business sustainability. So what I'm going to cover today is talking about the importance of clinical mastitis management. We understand that there is a lot more awareness and sensitivity around the use of antimicrobials now. We also understand that mastitis is the #1 reason why cows are treated for antibiotics. And after fertility or after infertility, mastitis is the #1 reason why cows leave the herd. And added to that, I think the strain on dairy producers with managing clinical mastitis through the number of cows that repeat after a first case of clinical mastitis provides a fair bit of angst, but also just that threat that antibiotics and antibiotic residues may reach the bulk tank does provide a fair bit of strain. So in preparing for this webinar, I've also spoken to lots of mastitis experts, both here and around the world, and certainly buried myself in the literature, but also spoken to a lot of farmers within Australia. And today, I'm very fortunate that four farmers agreed to be interviewed, and so I'll share some of their insights with you during the webinar. When I was reflecting on our discussions with those leading farmers, I realised that there was a common sort of characteristic, I suppose, in the way in which they were responding to the challenges put upon them. And that was in terms of accepting the responsibility of, managing the challenges and sort of being accountable for the changes that they make to improve and reduce the impact of clinical mastitis on their farm business. So we'll focus on finding, the importance of finding and promptly finding clinical mastitis. We'll get into some detail around whether a cow should in fact be treated or not. And within that decision sort of point there, we'll look at some of the opportunities that new mastitis diagnostics may have in supporting really good decision making with clinical mastitis and treatment. And then we're going to finish with talking about the treatment itself in terms of how cows are treated, but also we will get into some detail around treatments and using the evidence both in terms of the literature but also in the field. Of course, treatments are the final kind of say, and with treatments is that discussion with your prescribing veterinarian. But it's important to talk about the some of the evidence behind treatments, so you can have some clarity and really help with those discussions. Now, none of you online, I'm sure, will need any kind of reminder as to the losses associated with clinical mastitis. On many farms, the reality is that for every 5 cows that get clinical mastitis, 1 of them will need to be sold within that lactation. And it's not really good odds in terms of, and there's a number of people that are really concerned about that wastage, not only in terms of genetics, but also profitability. There are also lots of losses associated with products that need to be used, milk that is not only tipped down the drain or fed elsewhere, but also the reduction in production after a cow suffers a case of clinical mastitis. In 2014, we published the cost of a clinical case of mastitis as $277, and on using the same methodology, I did it just last week, looking at current prices and costs associated with managing clinical mastitis, it's well over $400. Now that's going to change a little bit with from farm to farm, but there's certainly some significant losses. And so throughout this webinar, we'll look at ways to minimise that impact. And as I said, there are some key ways to save some money, but also save cows' lives. And as a wise farmer from East Gippsland said 15 years ago to me, he said, "Mark, if you don't manage mastitis, it will manage you." So we'll get into some of the discussion around clinical mastitis. So how much clinical mastitis is too much? And it's very good business sense, I suppose, to look at bottlenecks, look at opportunities. And so right from the word go, Countdown develop some triggers that at least gives us a bit of an idea of what's an achievable rate of mastitis. And we've split this into calving time mastitis. So calving time mastitis is a cow that gets mastitis in the first 2 weeks after calving. And our level there is 5%. So 5% of cows that calve or lower is achievable on every farm in Australia. And in terms of during lactation, our trigger level is 2% per month during lactation. So let's put some real numbers around that. So let's say we've got a 400 cow herd. That means that if you calve down 400 cows, 20 cows with mastitis within 14 days is your kind of trigger level at that 5% level. And then during lactation mastitis, so that not past 14 days after calving, we're looking at around 8 cows with clinical mastitis per month, or 2 cows per week in, say, a 400 cow herd. Really, this webinar is about trying to demonstrate that every one of you can have a really positive effect on the outcomes associated with clinical mastitis. And for this webinar, at least, we are in the business of saving cows and looking after our business profitability. So to the important matter of finding clinical mastitis, I think some definitions here are really, really helpful. So to start with, I've got a table here looking at the forms of clinical mastitis. So, and the reason why this is important is that this will be, we can relate the different forms of clinical mastitis later to what's actually required in terms of treatment. So for some farms, whether a cow presents as mild, moderate or severe will affect the treatment that is offered to that cow. So firstly, with mild clinical mastitis, where it is just the milk. So again, countdown definition is clots or discoloured milk that persist for more than 3 squirts. And moderate, not only is there milk changes, as I've just described, but there's other changes, be it swollen, be it red, be it very painful, and maybe that cow's kicking a bit or acting up a little bit in the shed. And that's moderate clinical mastitis. And then, unfortunately, we've all had to deal with the severe clinical cases where not only is the milk affected and it is abnormal, the udder is abnormal, and the cow is systemically sick and she needs help in other ways. Okay, so in terms of finding clinical mastitis, we also know that a fairly large proportion of mastitis only presents with milk changes. So we need to check the milk. We can't see observable changes in the udder or in the cow. So quite a large proportion. Now we also know that strip checking does carry risk in terms of spreading bacteria when we're in fact trying to find it, but we're inadvertently spreading mastitis. So the ideal situation is that you only strip check when you need to. So when the bulk milk cell count goes up, if you're at a nice low level and you see it bounce, well then that's a good trigger. Or if there's clots on that filter sock after milking. Other farms do have the inline mastitis detectors in the long milk tube, and they can be very helpful when they're used in the right way. But inevitably, we all have to strip check. So taking some steps like trying to reduce the amount of milk getting on the gloves, and also regularly disinfecting your gloves in between stripping with 70% alcohol or a very good disinfectant. So when we're stripping, putting it on the ground, not into our glove, and then trying to identify those clots if there are there or not. So what about cell counts or the rapid mastitis test? Now, fantastic tools, both of these. Some people do use the paddle test, but they come with a fair degree of caution. So if we've got a cow that has no observable clinical signs, so there's no clots or discoloured milk and no udder changes, but yet they are positive to a rapid mastitis test, like a gluggy in that paddle, or the herd test comes back, like the one on the screen here, with some very high cells. So if it's over 250,000 cells per mil, that means that cow is subclinically infected. Now, the caution around this, there's some rules that are required, aren't there? Because I think every one of us have been tempted that we're going to treat this subclinical infection. We've found it, so we should treat it. But unfortunately, there's no return on treating subclinical mastitis during lactation. Of course, the best time to treat subclinical mastitis is in the dry period. So I am aware of some farms that have had to, whilst the rapid mastitis test is very, very good in terms of something that will provide more information and draw our attention to particular cows that need to be monitored. I do know of certain situations where farm managers or owners have had to remove the rapid mastitis test so that it is not used, because unfortunately it's led to a lot of over-treatment and wastage of money and wastage of cows. So then adding the subclinical to our sort of overall forms of mastitis, where that cell count is greater than 250,000, or it's a gluggy sort of reaction on a rapid mastitis test, we can put that into our same table here, but really be mindful that that's an indication that the cow needs to be monitored and certainly not treated. Whereas in the other, in the clinical, so clinical meaning that we can see changes without any other test. We can see changes in milk, we can see changes in the udder or behaviour of that cow, or in terms of severe clinical mastitis where she's at the back of the herd, her rumen feels reduced, her ears are down, and things like that, or her temperature is up if that is the case. So with these ones, we consider treatment. Okay, so then to look into some detail around the decision making, and as I said at the start, this is where we'll talk about the role that diagnostics can play with supporting good decisions with clinical mastitis management. Now, we know a lot about what reduces the chance of mastitis cure. Yes, there are some pathogen factors. We're aware of the inability to treat mycoplasma infection, the real difficulty to treat Staph aureus, certainly during lactation, and even during difficulty during the dry period in treating that successfully. And then there are other bacteria that carry a gene called beta-lactamase. That means that they are very difficult to treat. But then there are cow factors. So even if we don't know what is the bacteria that's causing the mastitis, we know that older cows, cows with previous mastitis, cows with previous high cell counts in their history, we know that back quarters and cows in later lactation when they suffer clinical mastitis, these all result in a reduced chance of cure. And these are really important in terms of providing, we know through evidence that these cows have a reduced chance of cure. So there really, yes, there's degrees of, but I suppose it provides you as farmers and decision makers more opportunity to say, well, what is my chance of cure when I line up to treat that cow? And then there's certainly a whole bunch of management factors that will reduce the chance of cure. Probably number one is poor hygiene associated with treating a cow with an intramammary tube. And closely associated with that is that there is evidence that full insertion of the intramammary tube, accepted just how hard that is, accepted how hard it is to not insert when a cow is misbehaving, but we know that reduces the chance of cure. Delayed diagnosis, not finding that cow soon enough, will also reduce cure rates, as will not following label directions. Okay, so that's really good information, and it may be obvious to those online, but really good to reflect on the evidence that we have around what we know about reducing the risk of chance of cure. Okay, this is some screenshots from my phone of a bovine mastitis cure calculator. We all like a few gadgets, and this has been developed by a colleague, Scott McDougall, and his team at Anexa. And I suppose it's just, providing some of that evidence that we have in a way that we can yeah, just really reflect on the chance of cure. So on the left here, we've got a cow, a young cow. She's only in early lactation. She has a front quarter affected, and she's infected with a strep bacteria. So she has a very high chance of cure compared to the older cow that has suffered a mastitis event later in lactation, and it's in a back gland. And what's more, it's associated with, is caused by Staph aureus. So you can see there that this is the helpful tool, but even without the awareness of the type of bacteria, experienced practitioners, experienced farmers know they inherently have built up experience about what's likely to actually respond to a mastitis cure. Because the faster we work out when a cow is not treatable, it's much better for you in terms of your business and profitability and your wallet, and much better for the rest of the herd in terms of the risk that that cow poses if she's retained within the herd. So let's take this opportunity to hear from Kim Buchanan from Cobram East about some of the decisions that she makes, decisions that she deliberates on when deciding whether to treat a cow with clinical mastitis.
Essentially, we'll look at how many cases she's had. If she's a problem cow, then it'll depend on, again, her, what I call her status. We'll look at her current production, we'll look at her age and any other factors in terms of udder or feet and legs or issues that she may have, her current PI, and consider those as a package as to whether she's worth treating to carry on, whether she's in calf or not, obviously is a really big one, and her stage of lactation. So we're fairly fortunate that we run an AffiFarm computer system in the dairy, so we've got access to current laid leaders, we've got live weights, we've got days of milk sitting right there in front of our nose, we've got treatment history and things like that. So we've got a lot of tools there to make informed decisions pretty easily. Those are the sort of things we'll assess in determining whether she gets treated or not.
Thank you, Kim, for those words and insight. So in this decision making, let's explore the value of culturing mastitis. Now, traditionally, this has been in mastitis investigations where we're trying to understand is most of the mastitis actually being caused by environmental spread, so that happening outside of the shed, or contagious mastitis, so things that are happening hygiene-wise, routine-wise, milking machine-wise within the shed, and having a great understanding of what is causing the mastitis. We all deal with limited resources. We have finite resources in terms of our mental space and our energy, and obviously our money to actually make changes on our dairy farms. There's lots of competing interests. So making changes without the guidance of understanding what type of mastitis you've got is not good business sense. The other reason traditionally for using cultures is when those countdown triggers that I've talked about in terms of calving time mastitis and during lactation mastitis, when those figures have been breached. I will add one more though, and that is if you've got, what is the percentage of cows that come back after having mastitis for the first time? So if you had 10 cows with clinical mastitis during a period of time, how many of them come back for a second time? Now, if that figure is over 2, well then there's certainly a stimulus to actually understand, well, what is the bacteria that's causing our mastitis? And it also supports culling decisions. There's people that occasionally go on staph hunts to actually look for their staph cows and then remove them from the herd to reduce the risk of that spreading throughout the herd to your valuable young stock and other stock. And then more recently, because we've got the ability now to speed up the process of those diagnostics. So there's a number of labs and vet clinics and even on farm that mean that within 24 hours, we can have a result of what's actually causing the bacteria, causing the mastitis in that particular cow. So in this case, we're using the results of culture to base our decisions on treatment. So here's some examples just here, a photo shared by Zoe Vogels in the presentation that she gave to advisors. These are on, you can see here the tri-plates that have different selective media that allow the person doing the test to more quickly identify bacteria, because usually it's been a longer period of time, 3 to 4 days, plus the transactions either end in terms of getting milk samples to the laboratory and then the results back, and sometimes a lot longer. And then there's more automated systems that can be used both in clinics or on farms. The master test shown there on the right of your screen. And really, so in this case, and some of you may be very familiar with this, but if you are using diagnostics to make treatment decisions, well then, as a routine, a sample will be taken from every cow and then sent or tested, and treatment is not started unless the cow is sick. So from the research that's been done, we understand that we can wait a period of 24 hours without a significant deterioration in cure rates. I won't say without any, because there's plenty of evidence suggesting that there is a slight reduction, but then there's other papers that suggest that there is no reduction in cure rates by having to wait. So when the result comes back, really what we're deciding on and seeking information about is that a gram-positive bacteria? And if it is, well then there's a higher chance that an intramammary antibiotic treatment has a positive effect on those cure rates. Whereas with gram-negative or no growth, if that's the result coming back after 24 hours, at least research from Europe, New Zealand and the US means that these cows, in fact, don't need any treatment. They could have some supportive treatment in the form of anti-inflammatories, but they don't need treatment. Obviously, this provides great opportunity in terms of reducing the amount of antibiotic use, but it comes with some limitations. So, and those are, I think we're all guilty of sort of accepting information on face value, but we need to understand that no test is perfect, and certainly some of the products that are available or that are offered in the market are not very accurate. So there will be false positives, there will be false negatives. And I think that's okay, because we don't live in a perfect world. And believe you me, there is a huge amount of current research on improving the accuracy of rapid diagnostics, not only for clinical mastitis, but in a whole range of things. But we do need to be really conscious that there are limitations in how we interpret those results, because there's some pretty big consequences if you make a decision based on inaccurate results. So there's certainly some challenges with products on the market at the moment, and with respect to an economic sense, whether there's worth it. Evidence is from probably the best paper to date a couple of years ago from a UK paper. The farms that are more likely to get an economic response from doing rapid testing and treatment, culture-based treatments, are farms with less than 20% gram positives. And I think in Australia at the moment, there's probably a very, very small handful of farms that would have their overall number of cases with less than 20% gram positive. So that's in the economics. Now, for some of you, economics may not come into it. That may be the way in which you want to progress and use antibiotics more wisely. Furthermore, there are some products on the market that purport to offer guidance around antibiotic sensitivities. And so what I'm talking about there is systems that that suggest the best antibiotic to use. And through a lot of discussion, research, and evidence, there is no way that we should be using antibiotic sensitivities to guide treatment decisions. And this is certainly the case both on an individual level, but also those products that offer to give some guidance with antibiotic sensitivities on a bulk tank level. But let's hear from Will Ryan, who's been able to use some rapid diagnostics and talks about, he's down from Gippsland, milking and managing a team, milking 420 cows or thereabouts in Gippsland, and talking about some of the benefits that he's seen with implementing rapid diagnostics on his farm.
Taking a sample of that cow through an aseptic protocol, making sure that the teat and the environment that you take it is as clean as possible. And then that sample is run through the mastitis sampling system, and we have to wait 22 hours for a result to come back. Now, depending on the condition of the cow at the point of sampling, we have a flow chart to follow, depending on if the cow is running at a temperature, if the udder is hot and swollen, or if the cow is clinically fine and it's just clinical mastitis that we're finding. After 22 hours, we've kind of got a bit of plan of action based on the mastitis results in place. What we've found in the 12 months that we've been using it is just reinforcing that cleaning process prior to administering the intramammary treatments, as well as that cleaning process taking the aseptic sample, I think has made a massive difference to the way staff view the importance of that process in the mastitis program. So we've seen a significant drop in repeat cases. A lot of that to do is just with the process of cleaning those teats thoroughly before administering the intramammary treatment. 30% of clinical mastitis cases that have been run through the mastitis are coming back as no bacteria present. So in that instance, the cow has actually dealt or had a clinical mastitis problem. She's dealt with the problem in her system. We're finding that about 30% of cases do not require any treatment at all, that those cows are clearing up by themselves, and that is, for us, is a significant cost that we are saving.
Thank you, Will. Will's just a terrific contributor, and sort of demonstrating how he's used the rapid diagnostics to benefit managing clinical mastitis on his farm. So now into some detail. We're getting into even more gritty detail about how we can improve the way we manage clinical mastitis. Now, as I said at the start, this is at its end a discussion between your prescribing veterinarian and you, but let's look at some of the breadth of issues associated with the treatments that we use, just to provide some guidance and help you with those discussions with your veterinarian. So working with your vet to choose a product, we've listed here, you'll note that nowhere on here is talking about antibiotic sensitivities. So more importantly, we look at responses in the past to treatments, and that requires a bit of work. That requires a bit of homework on your part in actually understanding how many cows that have been treated with a particular drug then come back for a second time, and trying to ascertain whether you're comfortable with the way in which that's they're responding. Previous cultures, as I've talked about before, will help some of the basis, but in essence, there is no evidence between the drugs with how they respond to different bacteria. There is no evidence whatsoever. All of the drugs available on the market have the ability to treat all of the bacteria that we get, save for the ones that I've mentioned. Dosing intervals might be really important for you and your business in terms of who is doing the treatment. So that may be mornings, it might be afternoons, but sometimes that's a really important part of making a good decision on a product. Withhold periods with milk can be really important. But having said that, milk withhold periods that, and we're all guilty of it, of actually looking at products that have a shorter treatment length and withhold period, saying, I've got to get the cow back in the vat, but it's futile if it's actually not doing the job. So having an understanding of those responses to antibiotics is really important. And certainly withhold periods with regard to meat, there are products available both with 7-day meat withholds and 0-day meat withholds available in discussions with your vet if you're not sure whether that cow should stay around, and then gives you more freedom to be able to make decisions on that cow leaving the herd. And other treatment length is important too. So let's talk about also the differences between intramammary tubes and injectable antibiotics. So we know that in certain areas, in certain farms, there are a lot of injectable antibiotics used for antibiotics. But we know that intramammary tubes result in 100 to 1,000 times the concentration in the affected quarter when compared with injectable antibiotics. We know that we're using 20 times less antibiotic. We know that these products are on average 80% cheaper than the injectable products. And what's more, we have the ability to actually use an antibiotic into a localized gland and not expose the rest of the body to antibiotic. So another way to put it is, if you're using injectable antibiotics, well, then you're exposing bacteria over the whole body, and certainly within the gut of the animal, that there is a higher chance of antimicrobial resistance being developed. So we're far more concerned about antimicrobial resistance being developed in the gut of animals rather than the udder of animals. I hope that sort of makes sense. And, you know, I think we sort of always ask that question, well, you know, or sort of think, well, more is better. You know, yes, I'm going to use an intramammary, but I'm going to use an injectable as well. And if there's no systemic signs of a sick cow, there is no evidence to support the use of injectable antibiotics as well as intramammary products. So this is another opportunity where you can save money. And at the same time, I totally acknowledge that all of us are trying to do the best we can by that cow and by our business, or the business that we're working in. However, in this case, it's actually misguided, because not only are you not improving the outcome of that cow's treatment, but you're throwing some money away, as well as providing more risk in terms of antimicrobial resistance, and just putting more antibiotics into the system, full stop. So injectable antibiotics can be used if a cow has multiple quarters affected, and a number of you will do that. If a cow poses a safety risk, and when it's better to actually put that cow in a crush and treat her more safely just with an injectable, or particular advice on groups where there's strep ag. Fortunately, there's less presentations of strep ag these days, but it is still around. There's some evidence to suggest that injectable antibiotics can be used in cows with severe mastitis, but there's probably even more evidence around the use of anti-inflammatories, which we'll talk about shortly. But with the use of intramammaries, hygiene is paramount. There is no point treating a cow with clinical mastitis unless the end of that teat is scrubbed clean with 70% alcohol. And so we know that there are very big differences between herds in terms of the number of cows that repeat after having one case of clinical mastitis. So let's take the example of 10 cows with clinical mastitis. On some farms, there is one cow that comes back for a second time out of those 10 in that lactation. And then in other farms, it's up to 5 or 6 of the 10 cows that repeat with a second case of mastitis. And it's nothing to do with the drug. It's nothing to do with the bug. It is to do with the hygiene and management around treating that clinical mastitis. So let's hear from Jason Graham. And for some of you that think you've got challenge in terms of really wet conditions, Jason farms on the Atherton tablelands, where there's 2.5 metres of rain on average per year. And he milks 1,000 cows and has, at the moment, through some restrictions, he has 2 teams of 6 people milking in 2 dairies.
We're really big on checking those detectors, looking for swollen quarters and all that stuff, getting it early. Because we've got a number of teams that come through the sheds and stuff, we're pretty big on protocol so that everyone's doing the same thing every day. Once they've decided to found clinical case of mastitis, then it's all about cleanliness. So the cups come off, they will then go through their protocol of checking the cow ID, the identification. One operator will then wash their hands, disinfect their hands, then dry their hands. Then the second operator will have clean hands also. One operator passes the person administering the drug first the teat wipe. They scrub the end of the teat, only the end. We're pretty big on just the end of the teat. Then they put that down. They both agree that they're treating the right cow. And then the second operator will pass the treating operator the tube. Very big on only inserting the 3 mil of the tube end. Slowly administer that tube, pinch the teat canal, work it up the teat, and then disinfect the whole other. And that's why we've got the 2 operators, so for safety, SOP, but also your senior operator would be the one administering, and then you've got your junior watching and going through that. So that's probably part of our training process, is they're getting to watch, and then they're talking about, they're looking, right, how do you handle that tube, the technique to handle the tube so the tube stays clean if the cow does move around. Obviously, if they get to a point where she's kicking and playing around, they'll probably start the whole process again. They just stop. One operator will get another teat wipe. Then we might administer a tail jack to make sure that operator can do it, safely, that's the first thing, and then properly. It's a team, and if you've got everyone thinking the same and knows the importance of it, and people that care, like these people, they're inexperienced, but they care about the cows, and that's what we sort of, as a business, it's all about how we care for the cows, and we try and do the best we can for the cows, and it flows through in attitude and milking and everything like that.
Thank you, Jason. So yes, just reiterating, we really do have one opportunity to save that cow's life and to cure her. obviously the second time a cow gets clinical mastitis, she's a lot more likely to end up being culled. One opportunity to cure her, or in fact to cull her. So we need to take good care with trying to improve our chances. So in terms of anti-inflammatories, is there benefit? Yes, with cows with systemic signs or an inflamed udder. So with anti-inflammatories, we're talking about Metacam, meloxicam, ketoprofen, key, tolfidine, flunixil, things like that. And there's growing evidence with the likelihood that we're going to get a response with using anti-inflammatories with even cows with mild or moderate clinical mastitis. In particular, studies from Europe suggesting that cure rates of certain bacteria will increase with the use of anti-inflammatories. But for some people, they don't need any more evidence. They know that a cow suffers under clinical mastitis, and this is being increasingly offered to support the therapy. So bringing this together, I suppose communication has got to be one of our greatest challenges as humans, and we need to look for opportunities and tools to support improved communication in amongst teams. And treatment protocols are not about a treatment protocol that's in the mind of your most experienced person on the farm. It is a written protocol of when a cow needs treatment, what treatments are to be given, how to administer the recording, the marking, and really importantly, how a cow should be culled. Now, this is driving another theme that's run through the farmers that I've spoken to is consistency. When there's consistency, there's a lot less room for problems when people go off script and things start getting into a bit of chaos and a bit messy. And this certainly relates to the situation around residues. So we want to do whatever we can to reduce the chance of antibiotic residues reaching the vat, the tanker, and certainly the milk silo. Now, milk companies have got some really key points of control such that antibiotic residues never reach the food chain, but there is a whole lot of issues along the way, and a couple of things I'll share with you, given some significant research and inquiry that one of the milk companies did in terms of our understanding of when residues happen. Now, firstly, the most important reason is when that cow is left within the herd, and totally understand the challenge with trying to manage two groups, but when there's errors around marking and how that cow is separated from the main milking herd, we've got higher risk. That risk adds up. And secondly, the use of products off-label. So what I'm talking about there is when there's a decision to increase the frequency of a particular antibiotic treatment or increase the number of doses of an antibiotic, that is an off-label usage, and the existing withhold period on the bottle will not be correct. And so that is a discussion when you do, when there's advice given that you need to go off-label, that is a discussion with your veterinarian, because both your vet and yourself take the risk. It's all on you in terms of going off-label on both the vet and you as a farmer, in terms of the risk of residues entering the milk vat. And these risks have to be managed. And so those 2 points in particular, in terms of segregating cows that are under treatment and off-label use, accounts for over 80% of the residue issues that cause our dear field officers and farmers a lot of strain and stress. So let's just lastly hear from Brett Findlay from Toong Upper in New South Wales and Victoria. The property goes across the border, on some of his experiences with written protocols.
Christina's an ex-public servant. She used to work with Phil Shannon at the department, and they got together and said, you need standard operating procedure for this. I thought, oh, not more paperwork, going to be buried in paperwork by the public servants. But actually, it works really well. We've got it written down. This is what we want to do. So if there's any doubt in anyone's mind, they can go and look it up and go, oh yeah, that's right, I'm supposed to do this and I'm supposed to do that. So we train them ourselves in the way we want it done, and then they've got access to the SOPs to refresh their memory on any part of it. You've got to keep looking for those opportunities. How can I make this system work more efficiently? Where's the next opportunity to get better? That's right. I know sometimes you look at problems and you think, hell, I don't know how I'm going to conquer this. And if you hear someone else who's done something and had a bit of success, or even if you just realise that, well, actually other people are in the same boat and, you know, this is not insoluble. If you start throwing a few ideas at people, it often sparks them up and they can see a way out of the hole.
Thanks, Brett. Really enjoyed the opportunity to talk to not only the people that we featured, the farmers that we featured, but many others in preparing for this webinar. And we'll continue to learn a lot from farmers that are implementing innovative ways to manage this challenging situation, as well as assimilating the knowledge that we have from very good research from both Australia and around the world. But I think these farmers have really shown, as I said at the start, the accountability to the challenge that they're facing, and also I think, you know, rather than be they're changing their systems to adapt, rather than be changed by the challenge. So we've covered you know, the importance of clinical mastitis management. We know this is a key area in terms of the way in which antibiotics are used on farms and the risks that pose, they pose. Some key elements of finding, deciding and treating, and I hope that's been very helpful, or just a very good refresher as to support really improved decision making. So in terms of, just in summarising, it is about building solid foundations with clinical mastitis management, and that starts with an accurate detection of clinical mastitis. So we're not talking about teat canal infections, we're not talking about subclinical infections. Having a written protocol so that it can be viewed by other people within the dairy, and striving for the consistency, because there's less errors when there's consistent approach to a problem. Choosing the right cows to treat, I think with the evidence that we have, both with and without knowledge of the bacteria, we can start to make some really good decisions about whether a cow should be treated or whether she needs to leave the herd sooner rather than later. And then all of our farmer leaders have talked about the importance of hygiene in using intramammary treatments, and the great need for using intramammary treatments rather than injectable products as well. And it'll always, with me, it'll always come back to prevention. So with this regard, having an understanding of the causative bacteria to prevent the next case. So it's never about, as I said, you can never treat your way over a problem, but we need to always be thinking about the next step of prevention with the next case. So with that, thank you very much, and look forward to some discussion and questions. I'd like to thank a whole bunch of people that have contributed to this. Certainly the farmers, people at Dairy Australia, Sarah, Steph, Rob Aiden and Harriet, Bill Morgan and Rob Moyle, Zoe Vogels, Mark Burgermeister and Sam Rao and Bill Tranter. Thank you very much. Now, I haven't been able to monitor any of the questions, so if there's questions for the panel, let's tackle them.
Awesome. Thanks, Mark. Great job. Yes, we have got quite a few questions that have been coming through in the Q&A section as you've been presenting, some really good ones. One of the things that I'm just very mindful of is it is 2 o'clock. So if anyone does have to duck away, this webinar will be recorded and made available. So if anyone wants to come back and listen to the questions, if you have to duck off, that's not a worry. But otherwise, we'll work through some of the questions. So Mark, one question that came up a couple of times, and I'm not sure whether you've got an answer for it or whether it might be worthwhile just having a discussion about, but is if full insertion of an intramammary tube decreases the chance of cure, why do we not manufacture tubes with a shorter nozzle?
Really good question. We have a number of people representing pharmaceutical companies online today. They have access to exactly the same research that we do. There needs to be better design. Yes, it costs money, but there is evidence that if we don't insert it fully, we get better cure rates. So it's up to them to get on with it. Unfortunately, I'm sure their margins are slim as well, but they should certainly be designed in that way.
Yeah, awesome. Thanks, Mark. So another question we had, has there been any studies on the distribution of intramammary antibiotics through a swollen and inflamed quarter as opposed to as opposed to a normal quarter? So when you've got swelling and inflammation in the quarter, is the distribution of an intramammary worse than in a quarter that wasn't showing those udder changes?
Yes, not that I can quote, but yes, that is studied, not extensively, and it makes sense that those animals with swollen quarters certainly would benefit, as I've suggested through the webinar, from an anti-inflammatory injection. But you know, spending a lot of time looking at the research, it's a number of these studies, again, it comes back to cost, but are not really designed, spec'd up in terms of numbers to properly understand a lot of that distribution. It's really expensive sort of inquiry. So that might be something that we can follow up with. Steph will record where that question's come from, and we'll do our best to follow up with some information there.
Yep, no, happy to do that, Mark. So another question, Mark, is how long after an intramammary treatment should you start to see clearing of the clinical symptoms? And when, what's the trigger to decide when you start retreatment of that cow?
Fantastic question. You can direct that to your prescribing veterinarian, but also, I suppose, you know, with that, it's a really good question, because if all cows, all people respond to infections in different ways. So we're seeing, in that regard, we're seeing the signs of inflammation. We're not seeing the signs of infection. That said, even if the clinical signs deteriorate, if they get worse, well then that's not a good indication as to what's going on. If they stay the same, I think you've just got to hold your fire, because there'll be variations within your herd with how they respond. So it's of concern if the signs stay the same, but I would just monitor for longer before deciding to treat for longer or change products, whatever has been discussed with your veterinarian. There's something else there. Yes, but if it deteriorates, well then you'd have to be, if the clinical signs deteriorates, that's when you need to be considering some other treatment. Yeah.
Yeah, that's great. Thanks, Mark. Another question that came through, which I might throw to you, Zoe, as possibly the best person to answer the question. So someone asked, what's the difference between gram-positive and gram-negative bacteria? What's the significance of the difference between those two types of bacteria?
Thanks, Steph. So gram-positive and gram-negative just describes how these particular bacteria stain under the microscope, and it has to do with how their cell wall is. So a gram-positive bacteria has a certain type of cell wall, and a gram-negative has a different type of cell wall. And some antibiotics don't, well, they'll work differently depending on whether they're gram-negative or gram-positive. But I think in terms of how Mark was talking about it, it also, so with their diagnostics, they'll often class all the gram-negatives together. So they'll be like your E. coli's, your poo bugs, and gram-positives are generally your skin bugs like staph, and also your streps that I think quite a few people would have come across. So it's just how it looks under the microscope, and it does have some implications on how the antibiotics work. And then also, I think, as Mark said, the gram-negatives are your E. coli's. You know, the cow's body is actually quite good at trying to get rid of E. coli's, and so that's why you don't actually need antibiotics sometimes, because the cow does all the work. Does that help, Steph?
I think so. If the person who asked that question needs any further clarification, perhaps just chuck a note back into Q&A. But yes, Zoe, that was a much better explanation than I tried to provide in the written Q&A, so that was fantastic. Okay, so Mark, this is an interesting one. So I'll throw back over to you. So one person asked, what could be causing improved cure rates with injectables used in addition to intramammaries in difficult cases? So I'm assuming that's an observed improvement in cure rates. Are you able to share some thoughts on that?
Yeah, I suppose it comes back to what's actually happening. Obviously, that's the observed improvement in terms of using an injectable as well. And I guess to ascertain the veracity of that, we do need to understand whether, in fact, it's to do with curing the bacterial infection, or the way in which that cow shows her clinical signs. As I said before, we're going blind in a way, because we're not seeing the signs of infection. We're seeing of a bacterial infection. We're seeing the signs of inflammation now. And I think and from talking with a number of farmers, the stage at which they actually assess the success of that treatment, they're sort of drawing that out a little bit more, because they know that, you know, this is severe infection, and there's a whole bunch of cows that are going to take a little while for the signs of inflammation, the clots and everything, to actually die down. And we know, in terms of cell count, that in fact the cell count will take in the order of 3 to 4 weeks to reduce. So I don't whether Zoe or you, Steph, can add further to that, but I suppose it's I understand what your question is, but I don't know why there would be that perception, whether there's some issues around penetration, and whether there's whether there's a higher need for anti-inflammatories in those cases.
Yeah, no, I think that's probably. Zoe, did you have anything else that you wanted to perhaps add to Mark's answer?
No, Steph.
Yeah. Cool. All right. So we've got quite a few questions that have come through, Mark. So probably what I will say is, if we haven't had a chance to get to your questions, I will get into. There's quite a few people that have put in anonymous questions. So if you've had a question that wasn't answered and you want to email it through to me, we can get back in touch with you directly. My email's on the webinar link. But probably one final question, Mark, before we close. Is there any benefit to rapid testing a cow that's finished treatment to check that her cell count is low before you put her back in the milking herd?
Yeah, and again, at its heart, everyone is trying to do the best, and you know, we want extra to sort of help and make decisions quickly. In terms of cell count, well, the question was around cell count just afterwards, and I've actually just talked about that. But we can't use cell count just after the treatment, because that's a severe inflammatory reaction that that cow's having to mastitis, and that'll take 3 to 4 weeks to dissipate. Quicker in others, depending on dose of the bacteria and things like that. But that may stay high, so representing in an individual cell count or a Gluggy paddle test result for a number of weeks. I think to take the liberty of furthering the question around should we take a sample in terms of trying to identify bacteria, I suppose if taking a diagnostic test at the end of a treatment, yes, you certainly could. And then if there was a no growth, well, then that would give you more assurance, more confidence to say, no, that's it. We're just going to wait for those cells to come down. But there's some costs associated with that. And also there is the inaccuracies or the sensitivities of that test. How, if a bacteria is there, how likely is it that we're actually going to see it at reduced levels and with antibiotics in the system? When we're investigating clinical mastitis, we tend to say, don't take a sample from a cow if she's been treated with an antibiotic in the last 3 to 4 weeks, because the antibiotic, whilst the bacteria may still be there, the antibiotic is going to interfere with that sample, and you're not going to get a very good result. Not going to get a very accurate result as to the picture. Yeah.
Yeah, that's great. Probably just one final one, Mark. Sorry, I know I said that was the final question, but this one's just come up a couple of times. A couple of people are asking how Staph aureus gets into a closed herd.
Yeah, it's probably been there for a very, very long time. There's certainly Staph aureus that can come, through the interaction with calves, and by, I suppose with a lot of bugs, we don't see the problem unless there's something that's happening that allows the expression of that, allows the spread of that bacteria. So it may have been there for a long time, but because of changes within the shed or routines, it may have led to more of a spread and seeing it more. But yeah, please, Zoe and Steph, chip in responding to that. Very good question.
Zoe, did you want to add anything to that?
Yeah, I guess, Staph aureus likes to live on the skin, and I guess, so I guess when you're talking about closed herds and the ones, the bugs that get spread when you buy in animals, it's those ones like strep ag and mycoplasma that specifically live within the udder. So the only way that they can kind of get into your herd is by bringing in that infected milk. But I guess my understanding was staph likes to live on the skin, and anything that impacts skin health, such as teat disinfection and teat disinfection and emollient, and the weather and how muddy and dry the teats get, that will impact how much whether Staph aureus is able to survive on the teat and then get into the teat canal and cause mastitis. I don't know, have I helped there, Steph? I'm not quite sure.
Yeah, no, I think that's great. So I was typing responses to the questions just as you were presenting, Mark, and my response is, so Staph aureus is found on the skin. It's found on everybody's skin. It's even on our skin. When it causes problems in a herd, it tends to be because there's some factor that's encouraging replication of lots of Staph aureus or survival of lots of Staph aureus on the teats specifically, and also some potential problem that's reducing the cow's ability to stop that Staph aureus getting inside the udder. So if you've got poor teat post-milking teat disinfection. Lots of Staph aureus can survive on the teat skin. And then if you've got damaged teat ends, as a consequence of, a high vacuum or over milking or something like that, then that then allows that Staph aureus to get into the udder where it's not normally found and cause mastitis. So it's found on the skin, it's found on our skin, and it's found on the skin of normal cows in normal healthy herds. So you'll find, my understanding is that even in closed herds that have been closed herds for 50 years, there'll still be Staph aureus on the skin of those cows, but it won't cause a problem until the post-milking teat disinfection or the numbers of bacteria on the teat or the teat defences are compromised in some way. So I think it's 2:15, so I think I might wrap up the questions there. So I just wanted to extend a huge thank you to everybody for logging in and joining us, and hopefully you got a few tips and tricks out of the webinar and have got some things to go home and implement. If anyone wants more information or they need some help, there were a couple of questions coming through in the chat with people with specific problems. What I would be encouraging you to do is to get in touch with a Countdown trained advisor. So on the Dairy Australia website, there's a list of about 250 Countdown trained advisors all over the country. So there will be one near you. And just encourage you to pick up the phone and have a chat to them and go from there, I guess, and see if they can help you with your specific issues. But otherwise, I'll endeavour to get back to those of you that had questions in the chat box that we weren't able to answer. So thank you very much, Mark and Zoe, for being our guests on the webinar for today and for all your work. And a huge thank you again for Sarah, to Sarah Thompson as well for her technical support. And yeah, we'll wrap it up, I think. So thanks, everybody.
Thank you, Steph. Thanks, Sarah and Zoe.